sounds. I'm Angus Wallace. I'm chairing this session. This is the first Faculty of Clinical Informatics webinar. It's being recorded, so everything you say is being documented. I'm delighted that all of you have been able to join us. We have 4 speakers altogether. I'm going to talk to you shortly about telemedicine for the shoulder. I'd like to introduce Suhail Chughtai, who is going to talk about Pakistan. Can you say hello, Chughtai? Suhail? No, you're muted. You're muted.
Yeah, hi, it's Suhail Chughtai from East London.
Lovely. Thank you very much. We've then got Tina, who is going to Tina Marshall. She's just going to introduce herself briefly. Can you unmute and introduce yourself, Tina, please?
Hello, everybody. I'm Tina Marshall, and I'm from Visiba.
Thank you very much indeed. And Dan Williams, can you unmute and introduce yourself?
Hi, everyone. Dan Williams. I'm a hip and knee surgeon from Cornwall and co-founder of My Clinical Outcomes.
Thank you very much. So I'm going to lead off, and the system here allows me to share my window with you, and I'm going to talk to you about experience with a shoulder telemedicine clinic in Nottingham. Now, Joe, I should have my first slide up on the screen. Is it up and is it clear?
Yes, yeah, that's showing.
Traditional telemedicine way back involved people, usually outside the UK, sitting in front of their monitor with a camera above the monitor and speaking to somebody at a distance. This has been done quite a lot in Canada and Australia. And this is a patient who has got a monitor on her finger for measuring her PO2 and pulse. And that was a traditional way of doing telemedicine. I set up a telemedicine clinic in 2011 at Nottingham University Hospital for my shoulder patients. And I did it because Nottinghamshire, which is the drainage area for the Nottingham University hospitals, is quite large. Parking at the hospitals is not easy. And for some conditions, you can actually manage people using telemedicine quite well. However, I had not anticipated the challenge of changing the NHS, and I'm going to tell you a bit about that. Initially, my plan was to use Skype, but unfortunately, the hospital said I could not use Skype because it was not safe, and that I had to use WebEx, which they had developed a contract for. Unfortunately, due to the broadband not being terribly good, I had to run the audio system different from the visual system. And we used BT NHS Meet Me with WebEx initially. What I hadn't realized is that there's a lot of information governance around, and confidentiality of the patient is important. Security of connection is important. You don't want to be examining a patient on Skype and somebody else accessing your Skype screen and causing a problem because they then copy the pictures on the screen. And security of storage is a problem, and there are NHS rules and European rules about where you can store your data. There are potential ethical problems that you need to consider. You need to carry out a risk assessment and management. And you need an infrastructure within the community to allow this to happen. Never underestimate the obstruction to changes within the NHS. The introduction of my pilot project in 2011 took 17 meetings involving either myself or my business manager, and we had to deal with the people I call, perhaps unkindly, the IT police. John Peach was the corporate operations manager, Rory King was the information governance manager, and Hugh Porter was responsible for the PCT service change group, and they all had to be involved. So our project was to evaluate the benefits and problems with running a new telemedicine clinic at Nottingham University Hospital. We did 4 pilot cases successfully in 2011. And I was then scheduled on Choose and Book. And my commitment was to demonstrate to the commissioners and patients that we had provided value. The requirements for a successful telemedicine shoulder consultation involve being able to get the patient into the system. You need at the other end, where you are examining the patient, a camera and a link. I started off communicating with the GP surgery, and it took us 2 months to get the WebEx system onto the GP's computer. You needed a computer. The alternative was to have a computer literate patient and a good computer with a good broadband link. X-rays you can pull up from the PAC system, but the easiest way of using that at that time was to copy the X-ray and show the X-ray directed to the patient. You needed a facility to trial the audio-visual link before the consultation. And you need the approval of the GP and the patient before you started. I have patients complete an assessment of their shoulder on an Oxford shoulder score before they start. And there are various shoulder conditions that I can carry out a telemedicine consultation for. Now, this is a lady who I won one of my early consultations. The picture quality is not very good. And I'm asking her over the internet to demonstrate how much she can move her shoulder. And you can see that she's shrugging her shoulder. And I'm going to take you along a little bit and show you the GP helping me later on with the examination. The GP is going to get up from her seat and you're going to get up from her. That's my fault. And there we are. Let me just move along here. I can get her to demonstrate to me how functional the shoulder is, and we use various tricks to do that. And I've got a litre bottle of milk that I have put in her arm, and she's now going to lift the milk up. You can see her shoulder shrugging, and therefore you can carry out an examination. It's different from the normal examination, but you get similar information. So the problems I had were getting computers installed with a webcam, problems with using WebEx. We had to resolve firewall and JavaScript problems. And I found WebEx not to be ideal at that time. I was able to assess patients with large or massive rotator cuff tears. I was able to assess a UK university student who was on an elective in Australia, a thalidomide patient in the States who wanted a second opinion about a shoulder replacement, a second opinion for a patient who had a poor result following keyhole surgery elsewhere, and a second opinion for a UK physiotherapist following shoulder surgery while in Saudi Arabia. All consultations were considered valuable by the patients. It was difficult to get GP buy-in because there was no financial incentives for the GPs, lots of technical problems, and despite having slots available on Choose and Book, only one was taken up. So that's my experience of starting up a clinic in Nottingham, and now I'm going to give up sharing my screen, and I'm going to hand over to Suhail Chughtai, who is going to tell us about his experience of using telemedicine in Pakistan. Yes, I mean Pakistan, I mean the whole country.
So, Prof, am I able to share my video?
Yes, you can. If you go on to, there's a bar in the middle of the screen. If you click on the upward arrow, that allows you to share. And you can share either your screen or you can share your presentation. Yes?
Yes, yeah, that's coming up.
Great. Well, I'm going to start off with an experience. I think we all know, most of us know definitions, explanations, the logic, the rationale. But I want to actually give you an experience, a very recent experience of making an impact through telemedicine. And I think that will say a lot of things, what telemedicine can do in a state of crisis, corona crisis. Millions are suffering from symptoms. 100,000 maybe are positive at the moment, and more people are becoming positive. But the scale of the problem could be bigger because we do not have PCR tests as much as we want to be doing. So in Pakistan, a country of 220 million people, where the hygienic standards are observed mostly by people who are educated in urban areas, but in the rural areas, they're not well practiced. The social distancing is not really a very fashionable thing, and it's very difficult to explain even. So I want to share now how telemedicine is helping us there. The government asked me to do something through telemedicine, and I set up a telemedicine hotline in Pakistan. And that whole process is not just putting a software. And that is what I want to emphasize here. That software is merely a tool. The whole paraphernalia of putting that software to use, I include that as telemedicine now, because without a paraphernalia of organizational structure and a concept, the software can actually fail and can disappoint people and put people off the tool. So how I did that was, first of all, let me explain myself first about what I do. I'm an orthopedic surgeon. I'm also a Microsoft certified specialist, and I've been doing telemedicine for more than 15 years now. Initially, I was designing, developing solutions. Now I'm consulting various organizations, even governments, about gaps of service where the delivery of care can be improved from point to point, or how can we equalize the physician density using telemedicine. So I've designed more than 20 solutions of telemedicine, starting from general telemedicine, then to specialized telemedicine, then to telecardiology, and going into very details of telemedicine, picking up one niche area. And that experience helped me to understand what problem you're facing in Pakistan and how can we solve by bridging the gap between doctor and patient. In Pakistan, we had a problem of patients not listening to the government advice. If they have flu-like symptoms, the first reaction is, let's go to the doctor. It could be corona. It was very hard to tell them that, look, you don't have to go to the doctor for basic checkup.
Okay.
And that is what I achieved by a system, not just software. So I spoke to the vice chancellors of 17 medical universities in Pakistan after my press conference. I invited them that, why don't you volunteer me 5 doctors each and just one room? And they said, what will you do? I said, I will set up your computers on Chrome browser, and I will give you a software, and I will link all your systems, every university, through one software of telemedicine. And all you have to do is rosterize your doctors 4-hour shift, so that there are at least 4 doctors online at one moment in the country on telemedicine helpline. So many universities agreed, because I got pushed from the government as well. The government then the government heard that, and they said, well, I think you may find a solution to the problem. Why not we support you? So they endorsed my idea. They pushed, and my voice became more powerful because the government was supporting me. And in 3 days, we got 8 universities signed up. And then we had experts, including Prof. Wallace. I requested his help, and many other experts from various countries, to supervise the process and fine-tune and remove any glitches if I had left some. So many universities joined us, and then I had provided the technology from London. I already had made a company in Pakistan to manage the ground operations. And then the university was going to the Focal University, Professor Javed Akram, the Vice Chancellor, the biggest university medical university in Pakistan. They have a jurisdiction of 56 medical colleges. So I spoke to their VC, and I made him the head of the committee. So Professor Javed Akram was the head of the medical committee. I was the technology in charge. Government was sponsoring any kind of glitches we had on the administrative level. Like if there was curfew, they had to provide us transport. They gave us a helicopter. If I want to set up a center in 4 hours in a new university, my team could fly from Lahore to Karachi in 1 hour, get the center set, and come back in 4 hours. So luckily I had good support. And then I started training my master trainers. Now these are the people there, this young guy, these 1, 2, 3, and 4 young guys. 2 are not so young, me and Prof. Prof may be young, but these four guys I picked up as brilliant guys with computer savvy skills. I trained them remotely on my software. This is a software I use. I've stopped using Skype or Teams about 10 years ago because I designed my own softwares for everything, every solution, for medical grade training solution, and online training, online classroom, telemedicine. I have my own range of softwares for everything. This is one of them. So I could train them at any time, and then they could train the doctors locally. And that helped me to minimize my effort and democratize and educate more people in telemedicine. And then I made one guy in charge on these master trainers. He's a senior dentist. He's an educationist, a professor, and he was looking after their problems if I was not available. And then this press conference, this was the start of the concept, where I introduced the concept on 12th of March. And on 19th of March, we had it inaugurated by the governor of Punjab, the largest province of Pakistan. So in 7 days, this idea was taken up, set up, and inaugurated by the governor of Punjab. They're now praying for the longevity of people's lives, and all those people lost lives. And then Medical City Online, my company, provided the technology. In 7 days, we got this installed and running. And then they inaugurated that the same day on the 18th of March. So now the Prime Minister came in. When he saw the results, which I'll show you towards the end, the impact, he said, I endorse this idea. Let the country support my idea. So luckily now we got endorsement of the Prime Minister, and they have given us a telephone helpline just in case from villages. If somebody cannot log on to the website, Doctors 24/7 online, they can call. This is 24/7 open. And then doctors, these are the screenshots of the web interface, may I say. And the doctors, young doctors, 1 year, 2 year experience, who have been trained on how to do a corona score evaluation and how to educate a patient on corona prevention and limiting the epidemic.
Unknown participant is now joining.
So this is how I train. Like, this is a center where I'm training, and doctors are keeping the social distance and watching all this training from me in Britain. I'm training them remotely on my software how to do the preliminary examination on this interface. And then it just snowballed. I mean, I was amazed by the reaction of doctors and the people. And I think it became a national phenomenon just in 3 to 4 days time. One university, second, third, fourth, every day we were going to one university using government helicopter and installing that. And this is one of the sessions of training in one of the universities. So the idea is that this is doable. This is actually one of my doctors, young doctors. I had them evaluated by a foreign faculty of mine. Medical City Online, my company, has two very significant people in telemedicine in America, Ned Thurman and Bud Zorowski. They actually assessed my system. I thought I may be partial to my system, but let them assess my system. So they assessed and they scored and they evaluated 9 out of 10 in terms of effectivity of communication.
Suhail, 2 minutes left.
Okay. This is just one example where one of the vice chancellors of a university showing the call center they set up at 1 day notice of my request. So what these doctors do, when someone calls, they open the Corona score on the screen. This is a Corona score where we ask few basic questions like travel history to the area where Corona has been known to be very prevalent. If there is yes, then we give 2 score. For flu, we give 1 score. Dry cough, 1. If there's none, then 0. Fever, and look at the exposure with Corona patient, 3. Friends and relatives, 1. If you're not healthcare worker, then 0. That includes nurses, pharmacists. Out of 10, if the score is less than 3, don't worry. You're less likely to have Corona. Just observe and kind of semi-isolate at home. 3 to 5, you are suspected to have Corona, COVID infection, 19 infection. So you can isolate. Now, it depends on the shortness of breath. That is not included there. If the person is short of breath, we ask them to call ambulance. If not, then isolate at home and confirmatory test should be done. We have a number in Pakistan, 1166. They would call 1166 and the guy will come and take a blood sample. And then if it's more than 6, then treatment should be started. Then the GP will be involved. Another GP, they will get a number to call another doctor who's locally, and they can either visit that doctor or the doctor can prescribe locally over the telephone. Now, the advantage of that is that out of 5,500 consultations we have done so far, most of them, these people would have gone out. They would have gone out to meet doctor. They would have taken a relative with them. That meant we prevented 5,500 people not to go out and take advice. And that was the one ring of infection we prevented. Not only that, telephone calls were about 15,000 telephone calls because some people could not call or some people's call dropped. So they converted to telephone. So altogether, 20,000 plus people we used. They went on this hotline, whether teleconsultation or telephone, and we prevented their movement from home. And we also educate them. My doctors.
Time. Can you wind
just
it?
Off 10 seconds. Is it allowed? 10 seconds?
Yes,
Just
10 seconds.
Yeah. So in this case, we are showing them diagrams, and then this is the impact. Corona telemedicine up to 30th of March, 36,000 total calls, and out of them, about 25% were teleconsultations. So we show them diagram. Prof. Wallace also helped me explain this concept in Britain on a BBC program, and he used the same website, Doctors 24/7 online. And this is a doctor explaining that a call from India came in, and she was thanking Pakistan. That's external impact. And I believe telemedicine culture is the matter. We cannot bring software alone. We have to bring telemedicine culture. And I believe strongly telemedicine is going to be the medicine. Thank you.
Thank you, Suhail. Thank you very much indeed. Can you hand your screen back to us, please? And I'd now like to ask Tina to take over and give her presentation, please, about the Swedish system that is being used in the UK quite a lot. Joe, can we help hand over to Tina, please?
that should be handing over. I think Tina might just be muted. I can just.
I was muted. Moment.
Over to you, Tina.
Sorry. Thank you. Let me just go to presentation mode so everybody could see my slides. And I just want to reiterate actually what Suhail was saying, and we haven't met before. However, you're so absolutely right. It is a culture for telemedicine. It's not the software. And so I'm going to come at it from the software angle. And we want to make it really easy for you. We don't want the software to be anything that's difficult. We want it to be easy so that your job and your role will carry on as it is normally. So let me go through and tell you a bit about Visiba Care so that you can understand why I'm here and why we can help. Although my slides aren't changing, there we go. Now, as we go through, right, I can show you a glance of Visiba Care. We are in 4 markets, 3 main markets, Sweden, Norway, and the UK. A lot of our customers are in Sweden, and we have over 13,000 professional users throughout through Visiba Care. We were founded 5 years ago with the goal of just making accessing healthcare easy. So for us, we provide a white label service. We're not doctors, we're not clinicians. We would provide you with the technology, software as a service, under your brand to enable you to see your patients. And I wanted to show you this slide to really show you how the consultations have been growing for us over the last few years. And you can see round to the end of 2019 how the consultations have been growing. Obviously, for February to March, there's been a significant rise in the amount of consultations that have taken place through Visiba Care in response to COVID, just for healthcare professionals who are seeing that they can operate in a different way. So whilst we've seen the curve has been happening, the growth has been happening, now we have significant growth. Now to show you some of the technology that we offer, again, it's really just to show you different things that you can do when you look at a technology partner. So you can look at things of having your video consultations. You can do messaging as well, so that you could have a asynchronous messaging. So of course you could have a consultation with a patient without needing to have the live conversation with them. You could have a number of people on the calls if you've got a patient with chronic illnesses, few more comorbidities. Drop-in rooms, of course, are really handy for post-operative care and for any patient that wakes up and feels as though they have something that they need to speak to somebody about, but there isn't an appointment. And as I've mentioned, it's white label, so it means that really it's under your brand. You own the app, you own your customers, i.e. your patients. And for us, we have a DNA rate of 3%, or rather our customers and our healthcare providers have a DNA rate of 3%. As Suhail was also saying, just to really tap into what he was saying there, being able to measure the satisfaction rates in the solution is so incredibly important. If it's not easy for a patient, and I mean this with whatever solution you use, if it's not easy for a patient, they're simply not going to use it. And you need them to use it, particularly more than ever now. Customers in our solution, they have a 3.9 out of 4 patient rating. So again, it's really high because it's so easy to use. And I can't emphasize enough, the technology should be easy for you. That shouldn't be something that you guys have to worry about at all. And of course, you want your teams to find it to be really, really easy to use as well. So those are things that are really key for you when you're looking at technology for doing and delivering telemedicine. I wanted to share this slide with you because this slide shows the number of different clinics that are using Visiba Care today. So they can be used in such a wide variety of different specialisms. As you can see, from GP practices, infectious disease, neurology, any aspect of your consultations where you don't have to physically touch a patient, you could do an aspect of that through a remote consultation. And it really is up to you to be brave and innovative and identify where that could be. And obviously, as you see, for now, we have to be rapid and we have to really get moving in delivering this. So with us, we've delivered 320 new clinics within 10 days to respond to COVID-19 across Scandinavia. And this is what we really need to see in the UK. So what can you do to really help with your virtual consultations? Of course, even now, even though we know that we need to have a rapid intake of this and we really need to get moving, people are still going to be a little fearful of new technology and how it will change their practice. So it's really important that you acknowledge those fears and that you identify it and then move on from it. It's really important that you work with your teams to identify which parts they can do as digital and which parts can be physical, because you really need the two to complement each other. And obviously at the moment, doing the physical consultations is going to be very, very difficult. When you're in the platform, role play with your colleagues. When you're in any solution at all, just role play with your colleagues to make sure that you're comfortable with what you're using and to make sure that you find it easy. And have a look at all of your guidelines and adjust these to digital. I mean, as it said, it should be easy for you. ENT, unless you're using a solution such as Endoscopy, that's going to be really tricky for you to be able to do over a virtual consultation looking at the ear. But obviously skin conditions, throat issues, those sorts of things will be really easy to see as well. Sexual health, mental health, orthopaedics, as you've already seen. Anything where you don't have to physically touch the patient, you can do through a remote consultation. And remember, the remote consultation could take lots of different facets. It doesn't have to be a video consultation. It doesn't have to be messaging. You could combine to something that suits you. And then just make sure as well that your teams have got even just the basic guidelines, if I'm honest, are really, really helpful. So in the back end of our system, we're able to look at, obviously, DNA rates, whether or not doctors are being booked, appointments available. And one of the things that we found sometimes is in our solution, for example, you would see a doctor's face as you're routing through the patient on the journey that you want them to go on. And sometimes it could be that the photo that the doctor has uploaded, they might have taken it from a funny angle. And so a patient's not booking for them. So it's things like that that can just be really helpful, and just make sure that you can provide headphones so that everybody feels as though they're in a safe environment.
1 minute.
Use your tech provider, whoever it is your co-worker, okay? Just make sure that you use their experience. Do not be concerned about that at all. Make sure that whoever you're using, you can share that technology and share those learnings, because that is going to be the key thing for you guys to be successful. Here are my details. We're obviously happy to help. But in the brief 10 minutes, these are the learnings that I can share with you.
Tina, thanks very much indeed. Much appreciated. We're now going to hand over to Dan Williams. Dan has developed his own web facilities through clinical outcomes. He's managing patients from afar, and he needs to do that because he practices in Cornwall, one of the furthest places in the United Kingdom. Dan, over to you.
Thanks, Angus. We co-founded My Clinical Outcomes some 10 years ago now. I want to focus today on our virtual follow-up of hip and knee joint replacement and share some of our experience with cancer care in Scotland. It fits really well with our current COVID-19 response, the link to which is on our website. And I'll also talk through some of the bits about the product, the client, and the benefits that we get. So My Clinical Outcomes is a digital health platform for remote long-term collection and real-time analysis of patient-reported outcome measures in routine clinical practice. Our COVID offer, we think, will help for those elective surgery patients that are getting postponed in large numbers patients who recently had surgery and are at risk at the current time of getting lost to follow-up, and particularly cancer patients who need to be safely managed at arm's length. And we're being radically flexible about contracts and commercial terms to work with new and existing partners to get our system implemented in a matter of days. We're currently in 70 plus hospitals with 1,000 clinicians using the system and 60,000 patients registered. And we cover PROMs in any condition and any specialty. There's a few of our partners in the NHS and private sector. And patients who register with the account get a regular automated condition-specific set of questions that are validated and are reproducible. It allows then the clinician to work with real-world evidence to assess individual patients and to inform treatment decisions, and to also look at cohort data to compare different treatments and different patient sets. There's analytics built into the platform, so you can see what patient engagement looks like. You can benchmark variation in outcomes from different procedures, and the raw data can be linked into any hospital systems securely or submitted up to registries and regulatory bodies, anonymous or pseudo-anonymous data as required. There's better outcomes for patients and an improved patient journey, so you can judge when to bring that patient back for face-to-face follow-up, not just at some arbitrary 6, 12-month time point in the future, which is particularly poignant at the moment. There's therefore operational efficiencies to be got from using the system, and we can evidence safety and performance data around particular treatments with the MCO system that's accredited by the bunch of acronyms down there in the bottom right of this slide. Focusing on virtual follow-up of hip and knee joint replacement in Cornwall, it's my personal clinical experience of using the system, where we initially got a productivity gain of converting 2 face-to-face appointments to 5 virtual clinic appointments. And over the first year, got ourselves within the commissioning guidance for the British Orthopaedic Association for follow-up of hip and knee joint replacement. Patients complete an online Oxford hip or knee score and a set of general health questions, pre, post-op, and into the long term. The patient can then see their recovery charted online. And as a clinician, I can group patient data together. I put this on my website so I can show it back to potential patients considering knee replacement. Also patients going through that recovery, so they can sort of see how they're doing compared to normal. And we've learned lessons from this program. We've learned what works and what doesn't. I'd echo what the previous speakers have said about the challenges of getting this done, with support from the Health Foundation for the first year, good commissioner support over the subsequent year, and it's getting that financial tariff in place that's been very important. But even still, we noticed that numbers dropped off in late 2016 as staff were quietly moved away from the program, and it's been getting a qualified Band-Aid nurse to run the program ever since that's worked well. So one person who owns the program, an arthroplasty care practitioner, and we've currently seen over 1,600 patients in Cornwall and about 30 patients per month. I draw everyone's attention in the UK to the national tariff for non-face-to-face follow-up that's available through NHS improvements. It allows you to get paid per consultation, per non-face-to-face consultation. But really, the story of this program has been how challenging it's been. I've failed to expand laterally into other specialties. We had 9 planned, and I failed to get this expanded out either regionally or nationally, despite my best efforts. What has worked for us is expansion into private healthcare, where there's been a real need. We partner with Spire Healthcare, which is the second largest UK private healthcare provider. since 2016. We provide scores for 7 conditions for 25,000 patients. We've got 800 clinicians registered with 500 new patients registering each week. And we submit data on Spire's behalf up to NHS Digital and the Private Hospital Information Network, with some lovely quotes from their Chief Medical Officer and Program Manager down on the right there. I think really some of the exciting stuff in digital problems is happening in oncology, with Ethan Bash's group in the States publishing a remarkable paper in 2017, comparing cancer care in patients with access to online PROMs against patients who don't have access or have standard care. Patients experience better quality of life. There was a reduction in emergency room visits, and patients were able to stay on their chemotherapy longer as toxicity symptoms were picked up more quickly. So the headline from this paper was that patients in that digital PROMs group lived for 5 months longer than those that didn't have access to it. So that 8% more of them were alive at 5 years. So it's got good coverage in the Financial Times and Washington Post, and with the Washington Post comparing it to a new cancer drug where you might get 4 months of increased benefit, but at a cost of $250,000 US dollars per year per patient to get that benefit. So that's been the springboard for us to work on the Cancer Innovation Challenge in Scotland, and with Macmillan to look at the short-term and longer-term toxicity effects of cancer treatment. So in our first trust up in Scotland, we've had over 700 assessments completed to date, with nearly 8% flagging a red category answer. So clinicians are being able to be more responsive to those toxicity symptoms, and the service is more efficient, and patients are positive about using it. It allows you this sort of analytics where you can look at the percentages of patients flagging red per cycle of chemotherapy and drill down into which symptoms, which toxicity symptoms are causing trouble here. So you can look at it for in this particular group, it's shortness of breath. With Macmillan, we're in a further 3 trusts on 7 NHS sites, with a 4th trust just come online. And 42% of patients are flagging yes to at least one screening question at 6 months, and over 90% finding the service useful addition. So we're inclined to agree with Dr. Richard Simcock, who's medical advisor at Macmillan, that what we're currently not doing prior to COVID is operationalizing the use of PROMs in a way that helps us understand how it impacts patients on a daily basis. But I think it's really become more relevant with COVID. And I echo what the other speakers have said today. So thanks for listening. I'd actually point any queries to our Chief Operations Officer if there are any inquiries after this. Sally.dams@myclinicaloutcomes.com. Our Twitter handle is @myclinicaloutcomes, and our COVID-19 response is available on the banner on our website. So thanks very much.
Thank you, Dan. I'm going to request control back. So hopefully I come up on the screen. Do I come up on your screen now, folks?
Not yet.
Somebody has given control. And give the control back, please.
I can see you there, Angus. It should be working okay.
Right. Okay. We're going to take questions now. Now there is a chat area, and you can ask questions in the chat area. I'm going to take the first question from there, and this was for Suhail Chughtai. In relation to your talk, Suhail, how quickly would your team be able to adapt their product to fit for purpose, for instance, in the UK? Bearing in mind the pace being worked at in this crisis. So can you just say how quickly you could do what you've done in Pakistan?
There are two ends.
Just let you.
There are two ends of the spectrum. One is patient education, patient convincing that this is for you. And the second is doctor training. But in this scenario, because of the speed and the political pressure, there's a third end, convincing the leaders, the political leaders. If the political leaders, the implementers, they are with us, then patients have to be given just a button to click. I didn't have a chance to show you the website page. It's like if you open a screen and you click a button, you straight go into the doctor's waiting room. So we have taken out all the complexity of making a booking or a scheduled booking or anything else. It's a press a button and go into the doctor's waiting room. On the doctor's side, the doctor has a waiting room area where the numbers are blinking. He's got spaces of 2 waiting room positions. Like if I'm seeing a patient, I can have 2 waiting room positions and they are blinking on the side of the screen. Once I finish that consultation, I can click another one. It just takes literally 1 or 2 clicks to get a patient on your screen. Once he's on the screen, then the system will walk you through it. Click here, do the history form, do that, this. So we are training young doctors through that as well. And literally many doctors went through without training because they had the system train them in 1 or 2 consultations. Time-wise,
I'm going to give you one more question.
Give us 24 hours and we'll set it up.
Okay, I'm going to give you one more question, then we'll move on to the others. Samrina has asked, Suhail, is it possible to carry out virtual consultations from the UK? And is there a place for pharmacists as I'd like to volunteer?
There is actually integration of pharmacy into our system. In Lahore, which is a city of around 14 million people, there is a chain of pharmacy who have actually been integrated into the system. So if a doctor writes a prescription, the prescription goes to the pharmacist and they will call the patient and they will ask, do you want it to be delivered by the nearest pharmacist? Or if you want to collect, we're open till this time and that time.
Okay, that's lovely. Now, anybody who's in the audience at the moment can switch on their microphone. They will appear in front of me and they can ask their question personally. Nobody's asking any questions. Can I ask Tina? Tina, how quickly can you set up a consultation in the UK if a consultant comes to you and says, look, I want to set up a virtual clinic? What is the process they go through and how helpful are the hospital authorities in doing it?
Oh, that's a tricky question, isn't it? So, well, the first part of that, it can be done really, really super quickly. I mean, like I said, we had 318 clinics in 10 days that we launched. So the technical part of it is
Sorry,
really simple.
I didn't quite understand whether that was across the whole of Europe or whether that was the UK.
No, so that is in Scandinavia. In the UK, what's happening at the moment, so we have been selected as a preferred supplier for video consultations by NHS England. They recently went through a new rapid procurement process, whittled down the list of virtual consultation suppliers, and we were selected as one. So that's really good. So honestly, it really depends on the trust in the provider. From our side, it can be really, really quick. It could take literally half a day, probably less than that, to get things up and running. From the trust side, we would need to have a couple of legal documents that go into the platform, and obviously your branding and your logos. So really, we can be really quick if the trusts can be really quick.
Thank you. And now, Dan, in relation to your system, have you got a problem with integrating with NHS computers? Is it done within the NHS computer system, or do you have to do it from your own laptop outside the NHS system?
I think I'd echo the answer of Tina, really, that it's really straightforward from our side. It just depends what system we're integrating into. And how quickly and responsive the trust can be. Getting things switched on from our side is really quick. It's a matter of hours. but it's on the trust side, and with integration of this data, just really depends what we're plugging into. But we've done it well with some of the national databases and some of our partners, Spire in particular, who wanted to do this. When you're working with an overall organization, it's been straightforward.
And one of the problems I spoke about was the IT police. And one of the difficulties I've had is that they seem to think their role is to make life difficult for you rather than facilitating you developing something new. And it's really frustrating when you are being innovative and they come along and say, well, you can't do that. And you say to them, well, actually, can you help me? And they say, that's not my job. But it actually is their job. It's their job to facilitate rather than obstruct. Have you found any problems on that side, Tina?
That's another fun question. Completely honestly, it really depends on the trust. You have some trusts where IT are all over it. For us, our solution actually needs minimal intervention from IT. The only thing we actually need IT to do is to make sure that you guys have got computers with webcams on, and just to let us go through like a handful of firewalls. So the work from IT from our side is quite limited, but you're right. In some trusts, IT like to hold on to things, but I think it's really, really variable to the trust.
I think one of the problems seems to be getting the consultation onto the electronic medical record. There has to be integration, and I think there is a problem with integration. I know that we've got Nick Booth here, who knows all about integration, and I wonder if Nick could come on and tell us how difficult it is to integrate something like Tina's system with the electronic medical record.
Well, that's a surprise question for me, Angus. I can't profess any expertise in this area. I think it will be very difficult, and I know that some of the industry groups who are working on the discourse channel of digital health have achieved that. I'm not sure how any of the current providers who've just been awarded status by NHS Digital on the preferred providers list can offer that. Sorry, I can't be more helpful.
So I can probably jump in on that one and answer a bit more about the integrations. So we have that question all the time about integration. So for us, we can do integrations. As Dan was saying, it really depends on the other provider and what we're integrating and how much we're integrating. What we actually find is that for technology such as ours, a lot of the time, everybody starts on the integration path, but then they actually find that they just want to have the consultation virtually, and then they take their notes as they usually do. But we have open APIs, and we have integrated with multiple EPR systems. So, again, it's not that hard, but we are on that list as well that you were just talking about.
Prof, can I reflect a slightly different approach to integration?
Yes.
My experience.
Can you introduce yourself, please?
My experience with integration has been in multiple countries, in Saudi Arabia, in UAE, Pakistan, Africa, in America. What I found was that integration is usually not required all the times. APIs, we have done API integration, but what I found simplest was that I open a screen share in my patient-doctor console, and the doctor can look at the existing EMR and then show it to the patient. And that is all that is required. And trusts are so happy with that because we're not pulling out their data. We're only looking at it without copying it. That was the fastest integration we did recently in a dermatology clinic in Bradford. We did not do any API. We integrated the system visibly so that notes were available to the examining doctor, and the consultation notes of my software could go back as a consultation summary, as a PDF file back to the NHS system as one record, consultation summary on that date.
So Suhail, if I can summarize, when you are seeing the patient on one screen, you have their electronic medical record on another, and you're able to use that. But finally, you use the documentation from your virtual consultation as your notes that are then put into the EMR.
Not on the other screen. In the same screen, there is an area for screen share.
Unknown
the patient's video will switch on
is
one
now
side.
exiting.
Fine.
And then that will replace by the patient's EMR available on that computer, which the patient can see as well.
That's lovely. Ladies and gentlemen, I promised that we wouldn't go longer than 2 hours. We've done very well. We are just over 2 o'clock. I would like to thank all the speakers. I'd like to thank Suhail, Tina. I'd like to thank Dan. And I'm very grateful to all of you for sticking to time. I think it's been a very useful webinar. It's our first attempt. And thank you very much for joining us and for putting up with our initial hesitations when we didn't quite get it right. And to the 20 people who have been observing us, thank you for visiting. This will be available from the Faculty of Clinical Informatics website in the future. We very much appreciate you attending. Thank you and goodbye.
Thank you.
Thank you. Bye.
Bye-bye.
Thank you. Bye.